Hi, I am Dr. Girish Chinnaswamy. I am Associate Professor in Pediatric Oncology, working at Tata Memorial Hospital, which is in Mumbai. As you are aware, Pediatric Oncology is a relatively new field in India, and it's an upcoming specialty, and the number of pediatric oncologists has only recently increased substantially. A bulk of the pediatric oncologists are actually trained in the West, and there are also in-house trained pediatric oncologists, but a substantial number of them are also trained in the West because formal pediatric oncology training was not existent in India till recently. So, initially the pediatric oncology training for doctors started as a short fellowship programs, 1 year and 2 year fellowship programs, but they were inadequate and or rather they were not enough for both in terms of number and with the depth of training which was being done, and hence the Medical Council of India has approved courses to start pediatric oncology 3-year DM program, which is the highest level of training you can get in India for a pediatric subspecialty. So, as it stands now, 2 centers in the country provide that kind of training. One is based in Mumbai at Tata Memorial Hospital, and other is based in Trivandrum at Regional Cancer Center. There is also another training program, similar training program, which exists in Chandigarh. Other than that, there are 1 year and 2 year training programs which give a shorter version of the training program, okay to do at a regional, not at a supra-regional or a regional hospital, but okay to take care of pediatric oncology at a much lower level. We need to escalate this program and get more pediatric oncologists trained here in the country so that we can take care of the large volume of children cancer who are there in our country. And as you are aware, about 20% of the world's cancer, childhood cancer, is in India. But we definitely do not have 20% of the pediatric oncologists of the world in this country. What we have is that in India, I think we do not have more than about 50 or 60 dedicated pediatric oncologists at the moment. So, let us compare it, for example, to the United Kingdom. The whole of United Kingdom sees about 1500 childhood cancer every year, and for that they have 125 pediatric oncologists. And the whole of India sees 50,000 childhood cancer per year, and for that we do not have more than 50 to 60 pediatric oncologists. So, you can even take large institutes in the world. You can take, for example, Harvard Medical School, Dana-Farber Cancer Institute, which is based in Harvard Medical School, and they have 43 pediatric oncologists for 350 cases, and that's probably the total number of, nearly close to the total number of pediatric oncologists in India we have to take care of something which is nearly 100 times more. One of the major problems in India is that lot of the tumors or the diseases we see in India come to us a few weeks later than what would happen in the West, and the reasons for that are many. One is that there is not a very high level of sensitivity among doctors in the community towards childhood cancer, both at the doctor's level or at the health worker level, for example, and for that reason patients tend to be diagnosed a bit later than what happens in the West. A significant problem is that we do not have a national integrated referral system of doctors where one doctor gets to see the same patient if the problem continues for a few weeks, and then the doctor will realize that there is something going wrong in this child, and so we need to now think a bit more laterally, and it is not a simple infection which the child has. Now, because patients have the liberty in India to move from one doctor to another, it all becomes a bit confused for the doctors, and it becomes difficult for the doctors to actually pick up that this problem has been going on for a long time. That actually allows the cancer to keep on multiplying and keep on growing because we have not started treatment early enough. So, compared to diseases in the West, and when we compare it to India, the tumor volume or the cancer volume is much larger. The disease is much more advanced in India compared to what happens in the West. Let us take, for example, a tumor called retinoblastoma, which is the commonest eye cancer we see in children, and this tumor occurs only in children and does not occur in adults. If you take United States of America, the cure rate of this cancer in United States of America is more than 95%, long-term cure rate, and the cure rate in India is 60%. It's not that we do not know how to treat retinoblastoma. It is just that in United States, the tumor is well located within the eye and not spread to the surrounding bones or to other bones in the body, because there the doctors pick it up quite early and make an appropriate referral, because they have systems in place to actually look for retinoblastoma. Whereas here the tumors are actually out of the eye into the surrounding bones, and that straight away brings down the survival rate by 30%. So, because there is a delay in diagnosis and a delay in referral to the hospital, the diseases tend to be more advanced, and because of that we tend to lose and not get the some of our patients and not get the same outcome what we would get in the West. And so the disease burden is much higher here. Even if you take bone tumors, the bone tumors are huge and massive by the time they reach pediatric oncology centers like ours. And if you look at the volume of the bone tumors what we see here, our tumors are much larger, double the size than what children would get in the West, and that is just because there is a delay in diagnosis and appropriate referral for the patients to reach here. So, we need to focus a lot on that, on educating the community, especially the community doctors, community health workers, and sensitize them about childhood cancer, because childhood cancer, if picked up and made an appropriate referral and treated well, has got an excellent outcome. So, more than 70 to 80% of childhood cancer would get cured on the long term. So, we also see that kind of outcome in select pockets in India where a referral has been made and they have reached the appropriate centers. But if you look at the whole country as a whole, lot of the diseases, childhood cancer diseases we see is much more advanced in India than what it is in the West, and that is just because there is a delay in diagnosis and a delay in the referral to the treatment center. So, the treatment guidelines in pediatric oncology, as you are aware, childhood cancer treatment guidelines were first more developed in the West, especially in Europe and North America before it came to India. And since a lot of the doctors had actually trained in the West, and this is a relatively new specialty, so a lot of the treatment protocols which were used were actually transplanted or imported from the West and delivered in India. Now, the problem of doing that is that different doctors have trained in different centers in the West, and there is a large heterogeneity in the type of treatment protocols which are being used, and that actually makes it a bit complicated for us. So, if you were treating a child in New Delhi and the child took half the treatment and wanted to do the rest of the treatment in Mumbai, and if the protocols are different, then it is very complicated to transfer the child from one treatment protocol to another treatment protocol. So, as it stands now, we do not have, barring a few diseases, we do not have uniform treatment guidelines and uniform treatment protocols for childhood cancer in the country, and there are many protocols which run in the country, but all these protocols are successful protocols. It is not that they are not successful, it just makes transfer of a patient from one center to another, collection of data, all that much more complicated, because they are not being treated on the same protocol. So, if they were all treated on the same protocol, then we would know exactly how this protocol would have worked in an Indian setting compared to a Western setting, or what do we need to make adjustments in the protocol for the country for us to get a better outcome. So, that actually is a problem which we are working on, and we hope in the next 5 to 10 years we will be address that in a big way, and we should have a uniform treatment policy across childhood cancer centers in the country. We do not have a large population based registry looking at childhood cancer in India. All the data which we have on childhood cancer in India is coming from hospitals where children are being treated. What we have noticed is the pattern of disease, the type of childhood cancer we see in India is pretty much similar to what we see in the West, except a few tumors. For example, the eye tumor retinoblastoma which I mentioned is much more common in India compared to North America and Europe. And but it is similar to seeing in, for example, in South America as well. So, in developing countries there are minor changes between developing and developed countries in the type of cancer we see. Otherwise, unlike adults, these tumors are not diseases of lifestyle and they are genetic disorders, and so pretty much the pattern of disease we see in the data which is reported from these hospitals is very similar to what we see in the West, except for the few diseases which I mentioned. However, since we do not have a uniform data collection mechanism in place across the country, and we do not have a population based registry for childhood cancer, we are relying on these hospital registries and another registry which is run by the Indian Council of Medical Research to provide us data on what is the incidence of childhood cancer we see in India, what is the stage of childhood cancer we see, how advanced are they or how early are they picked up, and what are the outcomes we are seeing. So, we need to put more effort into this and develop a good registry so that we are able to generate data and get Indian data on what type of cancers and how many cancers exactly we see per year, what are the outcomes we see, are they different from what we see today compared in India compared to what is in the West. And I think that needs a lot of effort to be done from our point of view. I think research and treatment of cancer goes hand in hand. And as part of the training itself, all of us pediatric oncologists and any adult oncologist would know that any cancer treatment which goes and the research has to go hand in hand, because it is a disease which doesn't have great outcome many times, although in children we get much better outcome. We must also, research has to be born out of the problems we see in our local area. So we have to identify the problems which we see in India and develop the research questions have to come from our day-to-day practice. So we have identified areas on which we need to work on. We know that children come a lot with malnutrition here, and the same treatment guidelines which are applicable in the developed world are not applicable here because the toxicity of treatment becomes very high. So we have to do research on how to handle children with malnutrition who have got cancer. How do we adjust the treatment doses? How do we adjust the treatment protocol so that we do not lose them because of the toxicity of treatment? Giving cancer treatment is a double-edged sword. On one end, you could actually cure the cancer, and the other end, you might actually harm the patient, including fatally, by having too much toxicity of treatment. So that is a very fine line, and there is a very fine window which we handle. And for that, it is very necessary for us to do research on our challenges, what we see in India, and malnutrition would be one of them. The other challenges are that we cannot afford all the treatment which is there in the West and assume that that treatment is the best treatment for in our setting. We have to develop our own protocols, our own treatment guidelines, and balance out the cost of treatment versus the outcomes what we see. And for that reason, we have to do a lot of research in the country to look at what would be the best option for our patients, especially with delivery of care in the community. And that becomes an important aspect. The third aspect is we have to look whether our cancer, the cancer we see in children in India are similar to the cancer we see with children in the West. Do they behave differently with the same drugs? The same tumor in India, in an Indian population, does it give the same outcome as in a Caucasian population? Is it because the cancer cell, the biology of the cancer cell, the function of the cancer cell in an Indian population is different from what we see in the West? So we have to do a lot of research on those aspects to understand the same disease in an Indian population so that we can actually tailor the treatment to what our population needs rather than take it from the West. So to do that, we have formed what is called the Indian Pediatric Oncology Group, and that includes all the pediatric oncologists from the country, and it is part of the Indian Academy of Pediatrics, Pediatric Hematology Oncology chapter. And we have formed various committees and subgroups, and the committees and subgroups meet now every 6 months in the country, and we have started this for the last 2 years. And we look at individual diseases, the subcommittees, and decide, and look into the problems what we face in India, collect data from various hospitals and say, this is the tumor which we are not doing well in India compared to the West. Let us do research on this. Let us see why our patients don't do well. Let us do the lab work on this. Let us develop new treatment for this. And like that, we are asking designing new research questions and new trials. And this is what the Indian Pediatric Oncology Group does, along with collecting data, along with developing treatment guidelines to make it uniform. The Indian Pediatric Oncology Group, the main mandate of Indian Pediatric Oncology Group is actually to develop research within India and ask the questions which are relevant for our country. In the West, most of the research has come through these large cooperative groups. Like in the United States, you have something called the Children's Oncology Group. In the United Kingdom, you have something called the UK Children's Cancer and Leukemia Group. So these are groups which have done research on this childhood cancer in multiple centers. So, the same research question, it is a multi-center trial across the country or across multiple countries. We need to develop that kind of research infrastructure in the country. We need to develop that kind of research discipline in the country, so that we are able to actually ask those questions in our setting and be able to answer the questions and improve the outcome of children with cancer.